The management of urinary incontinence in women. Introduction. Urinary incontinence, or UI, is defined by the International Continence Society as the complaint of any involuntary leakage of urine. Urinary incontinence, or UI, is a common symptom that can affect women of all ages with a wide range of severity and nature. Stress urinary incontinence is involuntary urine leakage on effort or exertion or on sneezing or coughing. Urgency urinary incontinence is involuntary urine leakage accompanied or immediately preceded by urgency, a sudden compelling desire to urinate that is difficult to delay. Mixed urinary incontinence is involuntary urine leakage associated with both urgency and exertion, effort, sneezing, or coughing. Overactive bladder, or OAB, is defined as urgency that occurs with or without urgency urinary incontinence and usually with frequency and nocturia. Overactive bladder, or OAB, that occurs with incontinence is known as overactive bladder wet, or OAB wet. OAB that occurs without incontinence is known as overactive bladder dry, or OAB dry. These combinations of symptoms are suggestive of the urodynamic finding of detrusor overactivity, but can be the result of other forms of urethrovesical dysfunction. Recommendations. Management of urinary incontinence. History taking and physical examination. At the initial clinical assessment, categorize the woman's urinary incontinence as stress urinary incontinence, or SUI, mixed urinary incontinence, or urgency urinary incontinence, or overactive bladder, or OAB. Start initial treatment on this basis. In mixed urinary incontinence, direct treatment towards the predominant symptom. If stress incontinence is the predominant symptom in mixed urinary incontinence, discuss with the woman the benefit of conservative management, including overactive bladder drugs, before offering surgery. During the clinical assessment, seek to identify relevant predisposing and precipitating factors and other diagnoses that may require referral for additional investigation and treatment. Assessment and investigation. Assessment of pelvic floor muscles. Undertake routine digital assessment to confirm pelvic floor muscle contraction before the use of supervised pelvic floor muscle training for the treatment of urinary incontinence. Assessment of prolapse. Refer women with urinary incontinence who have symptomatic prolapse that is visible at or below the vaginal introitus to a specialist. Urine testing. Undertake a urine dipstick test in all women presenting with urinary incontinence to detect the presence of blood, glucose, protein, leukocytes, and nitrites in the urine. If women have symptoms of urinary tract infection, or UTI, and their urine test positive for both leukocytes and nitrites, send a midstream urine specimen for culture and analysis of antibiotic sensitivities. Prescribe an appropriate course of antibiotic treatment pending culture results. If women have symptoms of UTI and their urine tests negative for either leukocytes or nitrites, send a midstream urine specimen for culture and analysis of antibiotic sensitivities. Consider the prescription of antibiotics pending culture results. If women do not have symptoms of UTI, but their urine tests positive for both leukocytes and nitrites, do not offer antibiotics without the results of midstream urine culture. If a woman does not have symptoms of UTI and her urine test negative for either leukocytes or nitrites, do not send a urine sample for culture because she is unlikely to have UTI. Assessment of residual urine. Measure post-void residual volume by bladder scan or catheterization in women with symptoms suggestive of voiding dysfunction or recurrent urinary tract infection. Use a bladder scan in preference to catheterization on the grounds of acceptability and lower incidence of adverse events. Refer women who are found to have palpable bladder on bimanual or abdominal examination after voiding to a specialist. In women with urinary incontinence, further indications for consideration for referral to a specialist service include persisting bladder or urethral pain, clinically benign pelvic masses, associated fecal incontinence, suspected urological disease, symptoms of voiding difficulty, suspected urogenital fistulae, previous continence surgery, previous pelvic cancer surgery, and previous pelvic radiation therapy. Symptom scoring and quality of life assessment. Use the following incontinence-specific quality of life scales when therapies are being evaluated: ICIQ, or International Consultation on Incontinence Questionnaire, BFLUTS, or the Bristol Female Lower Urinary Tract Symptoms Questionnaire, IQOL, or the Incontinence Quality of Life, SUIQQ, or the Stress and Urgency Incontinence and Quality of Life Questionnaire, UISS, or the Urinary Incontinence Severity Score, SEAPI QMM, or the Stress-Related Leak, Emptying Ability, Anatomy, Protection, Inhibition, Quality of Life, Mobility, Mental States Incontinence Classification System, ISI, or the Incontinence Severity Index, and KHQ, or the King's Health Questionnaire. Bladder diaries. Use bladder diaries in the initial assessment of women with urinary incontinence or overactive bladder. Encourage women to complete a minimum of 3 days of the diary, covering variations in their usual activities, such as both working and leisure days. POD testing. Do not use a POD test in the routine assessment of women with urinary incontinence. Urodynamic testing. Do not perform multi-channel cystometry, ambulatory urodynamics, or video urodynamics before starting conservative management. After undertaking a detailed clinical history and examination, perform multi-channel filling and voiding cystometry before surgery in women who have symptoms of overactive bladder leading to a clinical suspicion of detrusor overactivity, or symptoms suggestive of voiding dysfunction or anterior compartment prolapse, or had previous surgery for stress incontinence. Do not perform multi-channel filling and voiding cystometry in the small group of women where pure stress urinary incontinence is diagnosed based on a detailed clinical history and examination. Consider ambulatory urodynamics or video urodynamics if the diagnosis is unclear after conventional urodynamics. Other tests of urethral competence. Do not use the Q-tip, Bony, Marshall, and fluid bridge test in the assessment of women with urinary incontinence. Cystoscopy. Do not use cystoscopy in the initial assessment of women with urinary incontinence alone. Imaging. Do not use imaging like MRI, CT, and X-ray for the routine assessment of women with urinary incontinence. Do not use ultrasound other than for the assessment of residual urine volume. Lifestyle interventions. Caffeine. Recommend a trial of caffeine reduction to women with overactive bladder. Fluid intake. Consider advising modification of high or low fluid intake in women with urinary incontinence or overactive bladder. Weight. Advise women with urinary incontinence or overactive bladder who have a BMI greater than 30 to lose weight. Physical therapies. Pelvic floor muscle training. Offer a trial of supervised pelvic floor muscle training of at least 3 months duration as first-line treatment to women with stress or mixed urinary incontinence. Pelvic floor muscle training programs should comprise at least 8 contractions performed 3 times per day. Do not use perineometry or pelvic floor electromyography as biofeedback as a routine part of pelvic floor muscle training. Continue an exercise program if pelvic floor muscle training is beneficial. Therapeutic stimulation. Electrical stimulation and/or biofeedback should be considered in women who cannot actively contract pelvic floor muscles in order to aid motivation and adherence to therapy. Behavioral therapies. Bladder training. Offer bladder training lasting for a minimum of 6 weeks as first-line treatment to women with urgency or mixed urinary incontinence. Multi-component behavioral therapy. If women do not achieve satisfactory benefit from bladder training programs, the combination of an overactive bladder drug with bladder training should be considered if frequency is a troublesome symptom. Neurostimulation. Transcutaneous sacral nerve stimulation. Do not offer transcutaneous sacral nerve stimulation to treat overactive bladder in women. Transcutaneous posterior tibial nerve stimulation. Do not offer transcutaneous posterior tibial nerve stimulation for overactive bladder. Percutaneous posterior tibial nerve stimulation. Do not offer percutaneous posterior tibial nerve stimulation for overactive bladder unless there has been a multidisciplinary team or MDT review and conservative management, including overactive bladder drug treatment, has not worked adequately, and the woman does not want botulinum toxin A or percutaneous sacral nerve stimulation. Explain that there is insufficient evidence to recommend the use of percutaneous posterior tibial nerve stimulation to routinely treat overactive bladder. Alternative conservative management options. Absorbent products, urinals, and toileting aids. Absorbent products, handheld urinals, and toileting aids should not be considered as a treatment for urinary incontinence. Use them only as a coping strategy pending definitive treatment, an adjunct to ongoing therapy, long-term management of urinary incontinence only after treatment options have been explored. Catheters. Bladder catheterization, intermittent or indwelling urethral or suprapubic, should be considered for women in whom persistent urinary retention is causing incontinence, symptomatic infections, or renal dysfunction, and in whom this cannot otherwise be corrected. Healthcare professionals should be aware and explain to women that the use of indwelling catheters in urgency urinary incontinence may not result in continence. Intermittent urethral catheters. Offer intermittent urethral catheterization to women with urinary retention who can be thought to self-catheterize or who have a carer who can perform the technique. Indwelling urethral catheters. Give careful consideration to the impact of long-term indwelling urethral catheterization. Discuss the practicalities, benefits, and risk with the patient, or if appropriate, her carer. Indications for the use of long-term indwelling urethral catheters for women with urinary incontinence include chronic urinary retention in women who are unable to manage intermittent self-catheterization, skin wounds, pressure ulcers or irritations that are being contaminated by urine, distress or disruption caused by bed and clothing changes, and where a woman expresses a preference for this form of management. Indwelling suprapubic catheters. Indwelling suprapubic catheters should be considered as an alternative to long-term urethral catheters. Be aware and explain to women that they may be associated with lower rates of symptomatic urinary tract infection, bypassing, and urethral complications than indwelling urethral catheters. Products to prevent leakage. Do not use intravaginal and intraurethral devices for the routine management of urinary incontinence in women. Do not advise women to consider such devices other than for occasional use when necessary to prevent leakage, for example, during physical exercise. Complementary therapies. Do not recommend complementary therapies for the treatment of urinary incontinence or overactive bladder. Preventive use of conservative therapies. Offer pelvic floor muscle training to women in their first pregnancy as a preventive strategy for urinary incontinence.